Hello, good afternoon. You are all welcome to the first session of the NCDC ECHO interaction in this new year 2022. I want to say Happy New Year to the people I haven't spoken to this year. And we are glad to work with our partner, ECHO India, and of course, our mother organization, Infection African Network. Please, can you please mute your mic, please? Can everybody please mute your mic except for the person talking? Thank you very much. We want to welcome you all, and we want to believe that this is the year of infection control. We want to believe that WHO is going to take infection control to the next level. And our topic today, and I'm sure most of us have seen it, is a very common issue, antimicrobial stewardship. But we need to know more, and we want to listen to the people that have all the knowledge and all the expertise to share with us. And on that, we have two erudite lecturers or speakers that will take us through. And then we are going to have the Lagos University Teaching Hospital experience, what they've been able to do on this very important topic. I want to tell us to please take our biros and notes if you have questions and you want further interaction, so that this discussion will even be will go on beyond here. On this note, I want to invite my partners from ECHO India. Simran, are you there? Can you just say hi?
Hi, everyone. Hi, everyone.
Thank you. And I don't know if that, but I saw another doctor. Well, you know, the ECHO India are on, and so we have a very good interaction. I wish us very, very useful deliberation. And on the agenda, I want to invite Dr. Abiodun Egwuenu, who incidentally is an assistant director and the manager of Antimicrobial Stewardship at the national level at the National Center for Disease Control in Nigeria. She oversees the whole of the country. And Nigeria is not a small country. And I think all hands has to be on deck. Of course, she's a field epidemiologist. She's a product of Oladipo Aboderin University. That's where she had her first degree. And she had her master's from the Ahmadu Bello University, Zaria. She's been through the system. She's been through all this. She's been at the Federal Ministry of Health, but now she's domiciled in charge of prevention, the Department of Prevention, Programs, and Knowledge Management. I don't think we could have even have it better. So she's here to deliver to us what the situation is in Nigeria. Where are we in Nigeria, so that we know where we are? And after her, we will have Professor Aboderin to tell us what is happening at the University of Ife. So I wish us all the best. I want to invite Dr. Abiodun Egwuenu. You have the floor. Please share her slides. You are welcome, ma.
Good afternoon, everyone. Thank you very much for the introduction. So I'll be talking about antimicrobial.
Or should we share it for all? Okay. She's trying to load her slides. Please, can we please mute our mic so that we can all benefit from this discussion? Please, everybody mute your mic.
Infection prevention control center.
Excuse me, can you please mute your mic? No, please. Lekon, can you mute everybody except Dr. Egwuenu?
Okay, so can I start now, please?
Yes, please. But you can make the slide bigger. Okay, thank you. Very good. You can go on, ma.
Okay, thank you very much. So just to talk about Nigeria, before we talk about that, we talk about antimicrobial resistance. So antimicrobial resistance, by the way of definition, is resistance of microorganisms, bacterial, viral, parasitic. It occurs naturally over time, and it is actually a One Health challenge. So it is worsened by inappropriate medicine use, poor infection prevention and control, where these infections can spread from person to person, and then limited surveillance makes this worse. And we are also in a dilemma. The arsenal of antimicrobial agents, especially antibiotics, is diminishing globally. New antimicrobials are not being produced. And now throw this into Nigeria, where we constitute 47% of West Africa's population. Communicable diseases account for a majority of illnesses and deaths. It means that we are using antimicrobial agents intensively. The Abuja Declaration. Out-of-pocket spending for health is 70%, and so AMR is like taking over us. The rest has been
Hello, Dr. Egwuenu, can you hear us?
Please, can you hear me now?
Yes. Yes, please, go ahead.
Okay, so I've changed the network, so sorry about that. I think the internet was going on. So talking about Nigeria's situation on antimicrobial resistance and use. In 2017, a situation analysis was conducted, and we found out that in Nigeria, there are multi-drug resistant organisms recovered from bloodstream, surgical sites, urinary tract, and ventilator-associated pneumonial infections. These are the common hospital care acquired infections. And organisms that have been prioritized by the World Health Assembly were actually retrieved, in some cases, in up to 88% of the samples for each infection type. So it means that we do have organisms in Nigeria. And we also look at the drivers for irrational antibiotic use. So we do have people that are accessing antibiotics a lot, but there are also people that have issues getting access to these antibiotics. So one of the things driving inordinate access of the expectation of antibiotic from the patient side. And even from the prescriber aspect, we also noticed that prescribers with longer years of practice that are non-specialized, older age, were actually prescribing antibiotics irrationally. So this is a challenge within our community. And what have we done in response? Nigeria developed a national action plan in 2017. The plan will expire this year. It has 5 focus areas: increase awareness and knowledge of AMR related topics, build a One Health AMR surveillance system, intensify infection prevention and control in tripartite sector. So Nigeria's response is One Health in nature, promote rational access to antibiotics and antimicrobial stewardship, and also invest in AMR research and development. And since 2016, we now have a One Health National Antimicrobial Resistance Technical Working Group. The situation analysis from 2017 and address the four areas that I had mentioned previously. We also have a governing body called the Antimicrobial Resistance Coordinating Committee, which was inaugurated in 2020. This committee's role is to look at the evidence and provide policy guidance or briefs to the presidency and also to the ministers across the One Health sector. So this shows how AMR collates its information from the pillars, the 5 pillars, which constitute the National AMR Technical Working Group, and then through the AMR system to the One Health system, which comprises the One Health Technical Committee at the level of the ministers, and then the technical committees at the level of the Director Generals and Permanent Secretaries, and then the steering committee at the level of the ministers, and then up to the presidency. And then this is role connect with all relevant products to implement the national AMR, National Action Plan for Antimicrobial Resistance. The NCDC that was passed on NCDC in 2018 also drives this process. We also have a One Health AMR surveillance system, and here we can see that we have several hospitals in this state that have subscribed to the AMR surveillance system. And the images in yellow, we can see 2 yellow buildings. We have 2 national reference labs. The first one is the NCDC National Reference Lab in Abuja. And then we have University College Hospital, Ibadan, as the second national reference lab. Where we see the red microscopes are where for human health, the sites have been optimized. So the laboratories have been supported through the Fleming Fund Country Grant to have the capacity to actually do sepsis diagnosis, and also have been supported with We also have sites within the animal health sector. So we have 6 sentinel sites in the animal health sector, and NVRI, the National Veterinary Research Institute, INFORM is the national reference lab. And then we have in Environment a lab in Cannes with the Nesria laboratory. We also leverage the Global Health Research Units project in University of Ibadan for genomic surveillance, whole genome sequencing, assembly, and bioinformatics. And since 2018, we have been submitting data on antimicrobial resistance and also on our surveillance system to the Global Antimicrobial Surveillance System. And we have selected some priority organisms. In Nigeria, we focus on Staphylococcus aureus, E. coli, Klebsiella, and Acinetobacter, Pseudomonas, Salmonella in blood. These are priority organisms. And this shows that the majority of the use of is for Staphylococcus aureus, E. coli. And we have also detected multi-drug resistance in the isolates that we have submitted. So here is showing an example of an E. coli isolate from one of the sites that submitted data. And we can see there that there's resistance to ampicillin, ciprofloxacin, cefuroxime, gentamicin for this particular isolate. So this is an issue that is within the country. Now, putting this in the context of antimicrobial stewardship, when we talk about
We are sorry for the poor. Is the internet service? I hope she will come back. I hope she will come back soon.
Yes, ma'am, she's on.
Yeah, thank you.
Can you hear me now?
Yeah,
Yes,
we can
ma'am.
hear you now. You can go on, ma.
Okay, thank you. So when we talk about stewardship, stewardship refers to a coherent set of actions that promote using antimicrobials in ways that ensure sustainable access for all who need them. In Nigeria, our focus area 4 talks about stewardship, and we have 3 strategic objectives: improve access to quality antimicrobial agents, promote antimicrobial stewardship in humans and animals, and then strengthen regulatory agencies across all sectors. And I will focus more on the human health part. So we have several core elements for national antimicrobial stewardship. Our core elements are: we should have national plan and strategies. There should be regulations and guidelines for antimicrobial stewardship, which includes that the country must have an essential medicine list, treatment guidelines, regulations that talk about antibiotics prescription, that looks at bans, stockouts, counterfeiting, and issues around access. Another core element is that awareness and education for AMS must be in place, and there must be supporting technologies and data for antimicrobial consumption surveillance. Talking about the first one, national plans and strategies, we have the antimicrobial stewardship pillar within our governance structure. This pillar meets quarterly, and it is One Health. And it is a principal forum for optimizing antimicrobial utilization, regulation, access, and use. The 4 areas below: promoting safe antimicrobial use, advocating to key stakeholders, supporting national and subnational system on antimicrobial stewardship, and generating evidence. These are the key terms of reference for this group. And this group, I've listed some of the members of the group. So Nigeria CD, Agriculture, NAFDAC, the regulatory agencies, the research institute, the hospital representatives. And we look at these key areas: research and development, regulation and selection of antibiotics, procurement, supply and distribution, and at the tail end, prescribing, dispensing, use, and diagnostics that support antimicrobial stewardship. So for the national plans and strategies, we do have some of the key elements as prescribed by the World Health Organization in place. Then regulations and guidelines. The Nigeria has over 23 laws and policies and regulations looking at antimicrobial use, laws around medicine premises, but our regulatory workforce is quite low. So combining all the regulatory agencies that are available to guide prescribing, dispensing, access, use, both in human and animal, we see that it's over 100,000, which is quite low. Looking at the key workforce also that would actually work at the hospitals or in the community level, we can see that for medical doctors, we have 38 per 100,000, not accounting for migration or deaths. And for every pharmacy in the country, we have 15 over the counters. And this is even, the disparity is more in the rural areas where you might not even find a pharmacy, not to talk about a health facility for miles. So this is a big challenge in Nigeria. When we talk about the guidelines, we do have the National Essential Medicine List. We also have the standard treatment guidelines available. We also have a national drug policy. There is also an agency that assures availability of quality antibiotics. That is NAFDAC, National Agency for Food and Drug Administration and Control. So they secure the borders from influx of fake drugs. They look at the technical requirements for registering antibiotics. Now they have banned antibiotics for growth promotion and use in animals. They also receive reports of substandard or falsified antibiotics. We also have guidelines for hospital antimicrobial stewardship and a national antimicrobial stewardship policy under development. We have conducted a national antibiotic prevalence survey. Currently, we have 35 hospitals that are using the World Health Organization antibiotic use PPS in country, and antimicrobial stewardship interventions are planned in these hospitals with support from the partners that are listed below. But we do have gaps. One of the gaps is that the World Health Organization, what we call the AWARE classification, classifying antibiotics by access, watch, and reserve has not been integrated either into the National Essential Medicine List or the treatment guidelines. We have not yet looked at fixed dose combination of antibiotics ban in humans. So we have not looked at if an antibiotic has multi-molecules in humans, do we want to also limit access to these antimicrobial agents? Even though antibiotics are prescription-only medicines, this is not yet fully enforced because we do have access as an issue in Nigeria. There are people that need drugs, but these antibiotics, but they cannot access it maybe either due to geographical issues or even financial issues. We also need a mechanism in place to report shortages and stockouts. There is something in place, but it is not effective because the mechanism for shortages and stockout is more at the national level. It has not yet, it's not yet in all hospitals, and it is not yet as effective as it should be. And I also mentioned the issue of affordability. So these are some of the challenges that we are facing when we talk about guidelines and regulations. Now, talking about awareness and education, the World Health Organization prescribes that your awareness and education on AMS should be towards the public, schools, in-service trainings on the education curriculum via accreditation, and the guidelines should be operational. I mentioned that we have a guideline that is being developed. And why is this important? Studies, even in Nigeria, a study by Emel Ponko et al. Shows that rates in prescribing, good prescribing or poor prescribing reduced in hospitals that initiated antimicrobial stewardship programs. The quality of prescription improves, documentation improves, and targeted prescription also improves once antimicrobial stewardship is in place. In Nigeria, looking at the data that we have, we also see that in animals, because as I said, it is a One Health issue. Animals use antibiotics. Resistance can develop in animals to some of the microorganisms that are, especially organisms that are spread through gastrointestinal tract, that is through food and water. Humans ingest these resistant organisms, and then the cycle continues. So in animals, we can see that a lot of antibiotics are used, especially tetracyclines. And when we conducted a systematic review in 2017, we see that 46% of persons are using antibiotics without prescription. And even in the hospital, out of 2 patients are living with an antibiotic prescribed. So we do have a lot of persons using antibiotics in the community. And when we have done, after this, we've done several surveys. We can see that here we had a telephone polling in 2018, where people actually, when the question was asked that, do you think it is possible to have an untreatable infection? We see that 52% said yes, you can have an untreatable infection, and majority felt that you can prevent antibiotic resistance by avoiding abuse or avoiding self-medication. But in 2020, another study still shows that a lot of people are using antimicrobial agents. A study in Plateau and Oyo of over 2,000 respondents showed that for antibiotic prescription, half of the persons are using antibiotics via self-prescription. 47% purchase this over the counter without a prescription, and 77.7% get this from a licensed health worker. Understanding of AMR still remains limited, and access to healthcare and laboratory is challenging. So awareness and education is critical to antimicrobial stewardship. When we also did another study in Abuja, we can see that for this, 2,000 sepsis patients, over 2,000 sepsis patients presents in a hospital. We can see that for diagnostics, only 80 out of these 2,000 had a blood culture request, even though they were sepsis patients. So it shows that we also have a gap even in the hospital. The community, the hospital, there are gaps in knowledge and practices. So we do have several regulatory bodies that help and support antimicrobial stewardship, and they are embedded within the antimicrobial stewardship pillar at the national level. And since 2016, we have been engaging several stakeholders on antimicrobial stewardship and AMR. So, our key stakeholders include the general public through media. We also engage directly school children, health workers, researchers, farmers. We cannot say that we have included everybody, but we continue to engage because awareness has to be continuous. You cannot stop. So for the public, we've really gone every year in November. We have the National Antibiotic Awareness Week, which is drawn from the World Antibiotic Awareness Week, and we support sites to actually implement activities. And also, we are looking at how to embed this and raise awareness of AMR in our education, in our institutions, education institutions and health institutions. So we have done some mapping, seeing where we are. We can see that a lot of institutions do provide some training on AMR. So for medical colleges, veterinary colleges, laboratory science, pharmacy, there are trainings on antimicrobial resistance. And also for postgraduate fellowship programs exist for doctors, some for pharmacists, and some other professionals, including veterinarians. And now we are trying to pilot what we call the qualifying workforce in Asia and Africa on AMR and AMU surveillance. So the plan is to develop a module. The module has been developed with support from the Fleming Fund, and to pilot with 25 or 24 participants across the AMR Sentinel sites and TWG. The approach comprises self-study, virtual sessions, and face-to-face sessions. And we have had several trainings. And what the picture you see here is the training that occurred in June 2020. The plan is to now embed this training into the CPD or in-service training curriculum at hospitals, and also in doing in-service training or pre-service training. So there's a plan to have a meeting with the key stakeholders to embed such trainings. And then when we talk about supporting technologies and data, you have to talk about antimicrobial consumption surveillance, diagnostics, and use of antibiotic point prevalence surveys data. So this is just a pilot of a study that was conducted in Nigeria, looking at antimicrobial consumption surveillance. When you talk about consumption surveillance in this case, it talks about sales of antibiotics at pharmacy level. And when this survey was conducted, it was conducted with support from Fleming Fund, where 25 hospitals were surveyed and 27 retail pharmacies. There were 3 analysis levels. The first one was the primary analysis level, looking at the daily defined doses for antimicrobials. I will define some of these terminologies as we go on. And then we also looked at secondary analysis level to determine potential overuse of these antimicrobial agents. And then the tertiary analysis level looks at characterizing microbial use by time, age, and place. So time, place, and person. When we talk about the DDDs just means the assumed required daily maintenance dose per day for a medicine used, and it is only for adults. The reason why the DDDs came about, the WHO defined this when focus now came on antimicrobial use, is to standardize drug usage, to be able to compare drug usage between different drugs and between different healthcare environments. So it is a statistical measure. And this image here shows how it is derived. So for Nigeria, looking at the DDDs, comparing 2016 in 2017, 2018, we can see that Nigeria averagely we use over 4 million defined daily doses of antimicrobial agents, or antibiotics in particular, between 2016 and 2018. So it was averagely 4 million, and there was a slight increase between 2017 and 2018. And then when we talk about to determine potential overuse, that is the secondary level of analysis, which I mentioned earlier in the first image I showed. One of the key ways of defining potential overuse is looking at the WHO aware categories. So WHO aware categories categorizes antibiotics to access, watch, and reserve. The target is that in a country, 60% of the antimicrobials consumed must be within the access group, while watch and reserve should constitute 40%. And access group antibiotics are defined as narrow spectrum antibiotics. They should be the first or second choice for endemic therapy, and they usually offer the best therapeutic value while minimizing potential for resistance. The watch group are a broader spectrum of antibiotics. They should be used sparingly as first or second choice of antimicrobial treatment options for specific infections. when the infection is serious and are prioritized as key targets of stewardship programs and monitoring. For reserve, these are last resort options and should be only used in severe cases. They should be closely monitored and prioritized as targets of antimicrobial stewardship to ensure that they are continually effective. So I mentioned that our target is 60%. You can see here in 2018 was when we approached a little bit, we approached 60%, 59%. But in 2016, we can see that we are less than 50% for the aware category. So the aware is the light blue, sorry, access group is the light blue, and then watch and reserve dark blue. So we see that for all the years, we did not the target because the target is 60%. So we actually are using a lot of antimicrobial agents in the watch and reserve group. And then when it was now summarized by the molecule type, so in the access group and the watch group, in Nigeria for access group, the commonly used access antibiotics are metronidazole, amoxiclav, amoxicillin, doxycycline, and gentamicin. In the watch category, the commonly used antimicrobial agents is cefuroxime, ciprofloxacin, ceftriaxone, erythromycin, and levofloxacin. And 85% of the use was oral. And then when you decentralize or categorize by hospital versus community, on the average, 72% of hospital pharmacies, the target, they did not meet the target. So for hospitals, it was at 51%. So access group comes 51% of the drugs used, while for the community pharmacies, the antibiotics, the access group antibiotics comprise 63%, which is expected. So in the community pharmacies, majority may have stocked more of the access group antibiotics because they're also oral preparations. But we still have at least 56% of the retail pharmacies did not meet this target. So averagely, 63% of the antimicrobials used in the community pharmacies were access group, but 56%, that is 15 out of 27, still used more in the watch category compared to the access category. So this is still a challenge in the country. And now looking at all antimicrobial agents, just using the class, we can see that these 5 antimicrobial agents that I've highlighted with the green in green, we see that in Nigeria, I consume mainly penicillins, nitrimidazoles, fluoroquinolones, second and third generation cephalosporins. And these 5 groups accounted for over 60% of consumption. And I mentioned that cephalosporins, especially second and third generation, these are actually agents that should be in the watch group. So Nigerians, we are actually consuming a lot of watch antibiotics. And then when we look at child appropriate formulations, because access to this child appropriate formulation is also important, we see that there's a decline. So a lot of the child appropriate formulations are not available in pharmacies. A lot of people are now using adult formulations and either dividing the doses or reformulating for pediatric use. This is a challenge because there might be side effects, there might be issues. If the person cannot reconstitute properly, then the child might be overdosed, which is also a negative impact of antimicrobial use.
Dr. Egwuenu, I'm sorry I'm cutting it, but you have just about 2-3 minutes more. I know you have some.
Yes, I'm already at the end.
Thank you. Thank you very much.
Thank you very much. So antimicrobial stewardship, we need to consider awareness or behavior change. I think we need to move towards behavior change because what we have been doing is awareness. People are aware of the problem. Do they want to change? Do they not want to change? We need to get people to prepare to change, that is committed to change. We need to ensure that people have the willpower and they take action, change their behavior. And then we need to think of how to make this behavior so that they go and continue the new behavior, they are stable, or else they will relapse to the old behavior. And this is just showing where we are so far in Nigeria. We can see that when we talk about optimizing the use of antimicrobial medicines in human and animal health, Nigeria is still at level 1 out of 5. We need to really work hard. We've done a lot on coordination, but now we need to focus on antimicrobial stewardship. Our key next steps is we are working with several partners to strengthen antimicrobial stewardship programs in healthcare facilities and community. I mentioned the AWARE classification. This has to be included in our policy guidelines. We want to commence CPD-linked in-service training modules for health workers. We also want to strengthen diagnostic stewardship programs at hospitals. We will continue to increase community awareness on AMR, localize the understanding, and it is important to build infrastructure for AMR diagnostics because if we cannot improve access, we are still going to be treating more empirically, and we don't have data to actually look at our guidelines, our policy. And then we are developing with support from partners, what we call the AMR information sharing system. And we hope that a lot of people on the call will also subscribe to this system and share information on AMR surveillance and also antimicrobial use. And I would just like to say thank you for listening. We didn't do this alone. And these are some of the key partners working on antimicrobial stewardship in country. Thank you.
Thank you very much for keeping to time and loading us with a lot of information. I'm sure we are all very, very grateful. And I just want to tell us that if you have any comments, questions, or reaction, can you start typing it in the chat box? She will react to some of them there, and then at the end, we can have a discussion. On that note, I know Professor Aboderin has been on right from the beginning. We are really very, very happy to welcome Professor Shadi Ogunshola, Chairman of ICANN, and there are so many experts on this call. I want to just briefly introduce Professor. Whilst he's putting on his slide, Professor Aaron Oladipo Aboderin is a professor of clinical microbiology and parasitology, Obafemi Awolowo University, Nigeria. He's an honorary consultant. He's worked with the UK Fleming Fund, the AMR Policy Advisory Fellow for Human Health in Nigeria. He's the chair of the Nigerian Technical Working Group on Antimicrobial Resistance and member WHO Advisory Group on Bacteria Priority Pathogen List. His area of work includes infection management, antimicrobial stewardship, surveillance of antimicrobial resistance, healthcare-associated infection with more than 60 peer-reviewed journals articles. I give to you, Professor Oladipo Aboderin. Over to you, sir. Dr. Egwuenu, thank you so much. But we'll continue this discussion in the chat box. Unfortunately, we don't have all the time. Thank you. Professor Aboderin, you have the floor.
Thank you, and good afternoon, and distinguished audience and participants. So I'll be taking this presentation. Dr. Egwuenu has given us what happens at the national level. So to look at bringing it down to facilities, what do we mean when we talk about antimicrobial stewardship at hospital or healthcare facility level? Just antimicrobial stewardship. What's the need and who are the actors that can play in the field of antimicrobial stewardship?
Sorry, Prof. We cannot see your screen. What we're seeing is your downloads folder. We're not seeing the slide. Yes.
You haven't opened the PowerPoint. Open the PowerPoint.
I've opened it. Let me just stop here and start again.
Exactly, that is. Thank you.
Okay.
What about this one?
No, it's coming now. Yeah, it's on now.
Yes, so we'll appreciate that you put it on slideshow, PowerPoint slideshow. Yes, thank you, sir.
Or make it bigger.
How about this one?
Yeah, it's better now. It's good now. It's good to go. Thank you. Thank you very much. Now go ahead.
Yes, so I was saying these are some of the questions we would like to be able to answer number one, why do we talk about antimicrobial stewardship? What do we need antimicrobial stewardship for, if at all? And then what is really antimicrobial stewardship, by the way? What do we mean by stewardship? Where do we get it? Who are the actors, players? For instance, everybody on this call, can we all be stewards? Can we all be actors in this field that we talk about? If I don't have a stewardship program in my facility, how do I go about instituting or improving on my practices with respect to antimicrobial stewardship in my facility? What are the indicators to assess progress or success of my stewardship program? Where do I begin? When do I begin? How do I begin? These are some questions I imagine we might like to ask ourselves. Now, to have this in context, just last week, exactly a week ago, this landmark publication came out by the grant, which is supported by UK Fleming Fund, to give us global burden of antimicrobial resistance. And we have top causes of death globally. And there also we have this one about antimicrobial resistance, which happens to be one of the top causes of death globally. And there are two parts to this bar here. You see this one that is darker here. It has direct causes of death attributable to antimicrobial resistance. And it shows this from 0 to 2. This is in millions. So it means that currently now globally, 1.27 million people die directly related to antimicrobial resistance. And then 4.5 million are associated with antimicrobial resistance. This comes on top of what we know to be the old estimates. Until last week, we always said that every year, 700,000 people die from drug-resistant infections. But this new figure now tells us that really it's more than that, and that actually we have 1.27 million deaths annually, more than is coming from HIV/AIDS, more than is coming from malaria, that are attributable to drug-resistant infections when people are infected with bacteria and organisms that are completely untreatable. And we are talking of untreatable infections, not only in Nigeria or in Africa, but globally, whether in the best of healthcare systems in the US, in Europe, all over, completely untreatable infections that we see. And another concerning thing about that landmark paper that I talked about is the fact that when they now look at it at different regions, unfortunately, it happens that West Sub-Saharan Africa, that is West Africa, including Nigeria, that's where we have the highest burden of these untreatable infections. So we're talking of infections that we do not have effective antibacterial agents to treat. And we're saying that the greatest burden of all the regions of the world come in West Africa. And of course, Nigeria, just like Dr. Egwuenu has said, us 40% we are Nigerians. So where do we go? What is the cause of this problem of resistance untreatable infection? This slide is just to show us the key drivers, causes of untreatable infections. As you know today, the most important drivers of antimicrobial resistance is actually use of antimicrobial, as shown by these two big balls here, which tell us the use of antibiotics in human health as well as in animals. So use is actually the greatest driver. The more we use antibiotics, the more we press microorganisms to become resistant and to become untreatable today. Excuse me. And also, we also have healthcare transmission here, which is another driver of resistance. We have poor diagnostics, many times patient gets to hospital, microbiology diagnosis usually is the last thing people do in hospitals. You go for chemistry, you go for hematology, sometimes even radio diagnostics, but not microbiology diagnostics. So we do a lot of empiric treatment of infections, and all these are contributors to the problem of antimicrobial resistance, as you see. That's on one side of the problem. The other side of the problem is that even when microorganisms are becoming resistant, we do not have new drugs, we do not have new agents. The pipeline for antibiotics are getting dry. To make new antibiotics is not a lucrative business, because no sooner new agents come to the market, resistance develops. So pharmaceutical companies generally do not prioritize making new antibiotics. So we're talking about resistance. We're also saying that even the available drugs, there's a lot of use pressure on them. This graph is to show the volume of use of antimicrobials globally. Between 2000 and 2015, consumption of antibiotics increased by 65%, from 21.1 divine daily doses up to 34.8. So use is actually increased. And don't forget, the more these drugs agents are used, the more they drive microorganisms to become resistant, and the more the chance that they'll become untreatable. So we have a scenario where resistance is increasing, where no new agents are coming to the market, and so we continue to see more untreatable infection. Now, the problem is a bit complicated for countries in Africa and maybe Asia, because even the available agents that are still effective, we still have a big challenge in terms of access, to be able to get the access, either because the cost, access because of importation restrictions and all that go with it, so that even when you make a diagnosis, you need to treat, and then the drugs are not available within the country, or if they are available within the country to afford to procure them, it becomes an issue, and so infection remain untreatable. So we have the problem of access to this drug, or when you use it in excess, they also develop resistance, and so we need to balance this. So that is the background why we now talk about antimicrobial resistance. And this slide is just to show us, because over time, the development about what we talk about now, stewardship. We have heard of different words before. We have heard of responsible use, appropriate use of antimicrobials, rational use, effective use, or prudent use, but everything, it's just talking about stewardship. And it's actually the first time antimicrobial stewardship was used in published literature was around 1996, and it derived from those who read the Bible. When you are a steward, a good steward, and you keep what is entrusted to you. Antibiotics are public goods, and somebody has to be responsible to preserve this public good so that it will be available for as long as it will be needed, maybe for children, generations yet unborn. So that's the concept of stewardship, that we hold these public goods, antimicrobials, in trust to ensure continued availability for use to treat infections. And there have been different definitions, from trying to define what stewardship is about to how to do stewardship. So you have different definitions telling us you select dose, you select duration, you select a route of administration, or how do you do it? It talks about coherent set of actions that ensure responsible use. It talks about responsibility, taking responsibility. And that takes us to how we can all be stewards. This slide is to show the different actions and actors in antimicrobial stewardship. And it's not going to be difficult that everybody on this call is actually a steward, or should be a steward, and should identify being a steward, whether it's a nurse, whether it's a doctor, whether it's the government, whether it's a hospital governance, or whether it's pharmaceutical company, or whether it's the training institutions where we train doctors, nurses, pharmacists, or whether it's the patient themselves, or whether the person is a farmer. Everybody has responsibility to ensure that antimicrobials are available for use by taking different actions and taking different responsibility to ensure that we help to preserve and make these agents available for use. But our topic is about healthcare facility antimicrobial stewardship. So how do we do, what do we do, what does it involve to use it? Because we know that the hotspot of antimicrobial use and where we are driving for resistance is in our facilities, healthcare facilities, because we have patients that should be treated that are sick. And so pressure is more in healthcare facilities. And that is where everybody in the healthcare facility needs to take responsibility and action and become a steward for antimicrobial stewardship. So that takes us to what are those elements of stewardship program in healthcare facility. And so this summarizes the core elements of facility-based or hospital antimicrobial stewardship program. I don't think it should be a problem for everybody on this because these are IPC experts, and this is similar to what is the core components of IPC, whereby you have those 8 core components of IPC at facility level. But this time around, the core and the essential elements of facility-based antimicrobial stewardships are being synthesized into 6. So we have these core elements of antimicrobial stewardship. Sometimes you read some modern materials like CDC tells about 7 core elements, WHO talk about 6 core elements, but if you look at it, it's actually the same elements. Maybe you have 2 merged. For instance, you have accountability and responsibility merged together. This is WHO core elements of antimicrobial stewardship. And it talks about these core elements. Number 1, leadership. Leadership of the healthcare facility to support taking responsibility for antimicrobial use within the facility. I'll go a little bit into details in the next slide. It talks about accountabilities. Who are the people who take responsibilities for use of antimicrobial in our facilities, in our hospital? And it gives us a menu of possible interventions and actions on how to responsibly use antimicrobials in the facilities. And then education and training is core, pre-service training and in-service training. And then monitoring and surveillance, as well as providing reports and feedback on what you do in different facilities with respect to responsible use of antimicrobials. So we'll just go into details or examples and illustrations of how these 6 core elements of facility-based antimicrobial stewardship program play out. So if you talk about leadership commitment, what do we refer to? Leadership commitment means that in our healthcare facility, antimicrobial stewardship is recognized as a priority by the hospital management. It includes that in such a healthcare facility that there is an action plan of what to do in terms of antimicrobial stewardship. It might be a 6-month action plan, it might be a 1-year action plan. In December, just last month, a number of facilities gathered together. I think 9 facilities at Abuja with NCDC and WHO, and each facility had to draw an action plan for what they're going to do in their facility in terms of antimicrobial stewardship, and getting back to their facilities and with the management that this is the action plan. We have planned to do this. We have planned to inaugurate a stewardship program. We have planned to start ward rounds for antibiotics. We have started to do so. There has to be an action plan what that facility would do, and of course there has to be staffing standards, and like I said before, some of these things should resonate with experts in IPC. Of course, it talks about dedicated financing. These are core components. Of course, definitely it does not mean that every facility must have all those things in place before you start. It's just that these are things to work upon, and these are things to address or look forward to in any institution that is taking responsibility for how we use antibiotics and how we treat infections. And then the next is accountability and responsibilities. Who are the people that take responsibility, or that who should take responsibility if we do not have a stewardship program in our facility, or if we have already, like in some of the facilities across the countries now. So there has to be a committee, a multidisciplinary antimicrobial stewardship committee that has a clear terms of reference. And so infectious disease, the clinical microbiologists, pharmacists, nurses, IT specialists, everybody coming together in such a committee for that facility. And of course, you have those who see to stewardship day to day, so the stewardship stream. Then we also need to understand, and in fact, sometimes the people that might take responsibility might, because we're talking here about links between infection control committee and some other committees within the facility, like drug and therapeutic committee. Some facilities may only have IPC committee. The important thing is to understand the functions of stewardship, because you might end up being that the same set of practitioners who are doing IPC that will also take up the responsibility for stewardship. Or sometimes if you start with stewardship, you could have, depending on how large the facility and the kind of expertise you have, you might have separate committees, but it's just important to note the function and then to be able to constitute this group so that they will see to it. So with that responsibility, the other issue now is that what are the possible actions? And like I mentioned, you have a menu of what you could do. This is not, in fact, you have a long list. If you reference some of those documents like the WHO toolkit or the CDC toolkit, it tells about the possible actions that can be done. So we look at the context, we look at what is available to see where to initiate our program in our facility. So actions, we talk about treatment guidelines. Dr. Egwuenu mentioned of guidelines in development at the national facility can now decide to currently, I know it's in public review now, that they have for the first time what they call antibiotic a book that gives first treatment on different conditions, which again, we could adapt for our own local facility. So treatment guidelines that is adapted for you, the facility. Hello? Hello?
Yes, Prof, we can hear you. Please go on.
Okay.
Leko, please mute somebody. Somebody's making.
Yes, I have done that, man. Thank you.
So treatment guidelines, hospital formulary, and review, these are possible actions. So of course, if somebody is starting stewardship, you are not going to start antimicrobial stewardship grants in all the words simultaneously. You might just select one word, maybe that you think this is a low hanging, maybe children ward, maybe ICU, or wherever it's depending on the different for regular review of antimicrobial prescription and use in that particular. And as you make progress and can demonstrate success, you can then extend. But you have a long list of possible actions in terms of entry into antimicrobial stewardship program in our different facilities. Education and training, pre-service. There have been some publications in country that show the knowledge of healthcare provider about antimicrobials and use, and you will discover that we still need a lot of training about appropriate use of antimicrobials, not just while in school, in medicine, in nursing, in pharmacy, but even as practitioners, we keep on need to continue to inform ourselves about these agents. Now, whatever we do, again, I'm sure I'm talking to people that know that we need to monitor and have surveillance, and this is another core element. And here, point prevalence survey, which I'm sure many of us might have conducted point prevalence survey in our facility, because there are a number of published works on point prevalence survey on antimicrobial use within the country that seeks to know what type of antimicrobials are used in our facilities, what are the indications for use, whether we document those indications, How are we doing with surgical prophylaxis? What are the agents that are used in surgical prophylaxis? Are these agents used with appropriate laboratory investigation? So it's a way to know and to audit and to find out exactly why we are doing and to be able to set targets. Generally, many of almost all the point prevalence surveys done in Nigeria so far published, you discover that use of antimicrobials in facilities are generally which is really high, meaning that at least every 7 to 8 patients in our facilities are on antibiotics, rather high. And so when we measure, we're able to begin to set targets and say, oh, if we have this high rates, can we set a target to see if we can get use of antimicrobials maybe to 60% to 50% gradually and see how we do. It's not only a measure as PPS. PPS measure the quality of use, quality of prescription in terms of dose, duration, route, and other. But it's also important to measure quantity of antimicrobials that we use in our facility. That is measured in defined daily doses, as Dr. Egwuenu also mentioned the other time. And that's where the pharmacists are also very essential in this program, because from
Prof,
the
I may
pharmacy,
have to cut in. You have just about 2-3 minutes more.
Excellent.
I know it's a very interesting one, but
that's fine. That's fine. So I'm already in number 5. So
thank you.
Core component. So we do, and it does no good if we measure, if we do our PPS, and all we do with PPS is just to publish. If we do not feedback within the facility to know how we are doing, so there has to be reporting, there has to be feedback. It's not only PPS, like I talked about antimicrobial consumption that mentions the quantity of use, but also generates our antibiogram maybe annually to be able to see where we are doing, and all these are to set targets for what we do. So how do we implement stewardship? Usually start by finding out what do you have as strength in terms of stewardship, what do you have as weaknesses in your facility, what are the opportunities, and there's so much opportunity now in country from what Dr. Egwuenu has said. The country is having so much support now for different facilities, and look at the check and then see where you want to be. Everybody should be able to locate an entry point. This is just another tool by WHO that helps to assess where a facility is here, whether at 0 level or whether you are started program, and then you can plan what you want to do. So the challenge is not to stop, but to see where we can initiate interventions. Currently, a number of facilities, listed some of here, are being supported by different partners. I know UK Fleming Fund is supporting you, so it's Commonwealth Pharmaceutical has been supporting it, and I'm sure many more players are coming. So every facility, there's no reason why any facility should not be planning or should have started an antimicrobial stewardship program to ensure that antimicrobials are available for continued treatment and management of infections, so that we'll be able to address this burden of death from untreatable infections. Thank you. Over.
Thank you very much for that loaded presentation, and I'm sure the stewards, we're all stewards. Everybody should know where they come in. Unfortunately, we are short of time, but the discussion will continue. I'm going to invite the last speaker before we discuss, but like I said, we can put our comments, in the chat box, and I'm inviting Dr. Chioma Oswagu from Department of Microbiology, College of Medicine, University of Lagos. She's a consultant microbiologist and parasitologist, a research fellow. She's done so much, but then she's an IPC change agent because she's gone back to sharpen her wits. She's done the basic, the intermediate, and the advanced course, and she wants to share with us the improvement in IPC practices at Lagos University Teaching Hospital. You have 10 minutes, Chioma. Thank you. Thank you. Go ahead. You have the floor. Chairman, you have the floor. You have the floor.
Okay.
Dr. Swag.
Yes, ma'am. Thank you for giving me this opportunity to make this presentation. Thank you, everybody that is on ground to listen to us. I want to start this presentation by thanking our mentor, Professor Ogunshola, who made this training possible for me. And I also want to thank all her collaborators. If not for her, we wouldn't have been able to attend this training. And the training has opened my eyes and made me more sensitive to IPC issues. And I cannot be grateful enough. I also want to present our team, the IPC team in Lutz. The IPC committee is Professor Odiebo, IPC committee chairman. Dr. Shu is the focal person for Orange Network in Lutz. And we have Ms. Okusonya, the IPC nurse, and myself, who is a graduate from the IPC training, IPC diploma. So we have the link nurses as members of our team, and we work with the link nurses. We have our meetings and discuss things, and the link nurses we carry to the wards. We've been able to develop our IPC manual, and it's available. And we have done training on it, and we have started making use of what is in the manual, and the manual was also improved as a result of the trainings that we got before it was finally published. So during our infection control meetings, we stepped down the things we learned during the IPC diploma. We're able to use it and step it down to the resident doctors and make it able for them to be able to carry out improve their IPC practice, because we work with the resident doctors to do IPC things in Lutz. So during our meetings with the resident doctors, we step down whatever we learned to them. We also reestablished, at a time, the meetings with the link nurses, especially during that COVID time, was stopped, but we have been able to reestablish our IPC meeting with the link nurses, and the trainings we had, especially behavioral change communication and presentation skills, is able to make us more engaging with our link nurses and making the meetings more impactful. We do this train other healthcare workers on IPC issues. So we participated in Professor Ogunshola's environmental toolkit project, where we trained cleaners in pediatrics on how to do proper cleaning of a healthcare facility. And it was also an interesting eye-opener. It also sharpened the practices. So with the trainings that were given to the pediatricians and the pediatrics unit, it has also cascaded to the other people, and the cleaning in the facility has improved. We train medical students on IPC training, and we were able to use what we learned during the training to improve practices in the training of medical students. Another thing we do is in collaboration with Antimicrobial Stewardship. So we are able to use the skills we learn in interpersonal relationship and how to relate with other people to also be able to work with the AMS team and the laboratory, microbiology laboratory, in carrying out our IPC practices. And we can say that our outbreak has been reduced because we have most of the work we do, we concentrated on the pediatrics department. And that's where the outbreak usually occurs. But since after our training, we've not had any outbreak in pediatrics unit. So I can say it is because of that training that we were able to reduce the outbreak in the pediatrics unit. So most of the usual practices are alcohol-based hand rub is produced by the pharmacy department, and we're able to the uptake of the hand sanitizer has improved. So with the help of the Orange Network, we were able to get posters that we placed at strategic places as reminders, so that our trainings, when you train somebody and you don't remind the person may likely lose a hold of what they learned. So we have workplace reminders in strategic places, like this is how to do hand hygiene. We tested in many aspects of the hospital. Though we had some challenges, we are not yet there. We still need to improve. We need to improve, especially on our monitoring and evaluation. We have been training, but we've not been able to monitor effectively. Based on what we have learned, we have plans to institute some monitoring of some IPC issues like hand hygiene and surgical site infection. All these monitorings have been done as a project by people, but we want to do it as IPC now. We also, because of the behavioral change communication, our attitude to people has changed. We are able to engage people. We're able to be more, how will I say it? More effective in our approach in talking to people when they're not doing what we think they should do. So instead of just condemning them outrightly, we speak to them in a way that we make them to want to change. And we hope to continue improving on that side. Then we also need to improve our engagement with management. We need to talk to them more so that they will understand the importance of what we are doing and be able to assist us or help us to do our work properly. Other challenges include funding. We always have challenges with funds. Even some of the activities we may want to do are stalled by lack of funds, and we just park them one place and wait for when we get funding. But we hope to look for alternative sources of funding so that our work will continue. We have a shortage of manpower, and that's why our link nurses are overworked and they've not been able to perform their optimum capacity. They have the knowledge, they're willing to work, but they are somehow overworked because people live for greener pastures and they are not really replaced immediately. But we have poor attitude to healthcare, poor attitude of the healthcare workers towards IPC, but that one is changing. The attitude is improving now because of the trainings that they have got. But we want it to change in such a way that they'll be more proactive. Like if there are no bean learners, they will not wait until we talk to the people that bring, they will be the ones who request for the bean liners and make sure that it is there. Thank you.
Thank you very much. We've had presentation from Dr. Abiodun Egwuenu giving us the national outlook. We had the health facility approach from Professor Oladipo Aboderin, and now the experience improvement plan. So it is not written on stone. IPC has come to stay. Everybody should look at it and know how to make a difference. Now we are open for discussion. You either put up your hand. I can see that Professor Aboderin is already exchanging comments on the chat box. You either put it in the chat box or you put up your hand so that we can discuss, so that we can finally round up. It's been a very beautiful day. I want to appreciate you all for your participation, for creating time out of no time. But I hope the afternoon has been useful and fruitful. Thank you. Now, I hope I'll be able to see the hand. Professor Aboderin, I saw you were responding to a chat. Yes. Can you put up your hand if you want to talk or ask a question or need clarification? There's a lot of accolades for the presenters today. It's been a very fruitful day for me, and I'm sure for all of us, because we are all stewards. Today, we are all stewards. Hands up if you have any comments, reaction. Lekon, please put in the chat box the feedback for the session so that people can be feeling that, so that we can make the session better. This is the first session for the year. I'm waiting for hands to be up. Professor Aboderin, can you just, what you just typed in, can you just say it maybe to make people, I haven't seen any hand up.
Yes,
Are we tired?
I saw a question or comments on the the chat about central coordination, where I thought and I just try and respond that for a facility, yes, there is need for an antimicrobial stewardship committee, because that would be like a management committee that provides direction for whatever stewardship practices and program to be done in that facility. They are not the one that would do the day-to-day stewardship intervention out of the menu that I talked about, but they will provide direction and support and at the management level. And the composition of that group depends on what's available in a facility. Ideally, you should have a leader, a chair of that committee, who ideally should be somebody who has expertise in infection management, and the clinical microbiologist, as in many for Nigeria, infectious disease physician, and some other infectious disease pharmacist. That is, but the day-to-day implementation of antimicrobial stewardship intervention will be by the antimicrobial stewardship team. And to my mind, this should not be difficult to also understand, because I think it's something that is like the kind of thing that happens with infection prevention and control. We have many institutions, you have the IPC committee, but they are not the one that go around for the surveillance and all that. So that's just the kind of thing that we have. It's over. Thank you.
Any other comments from any of us? I haven't seen any hand up. Any other comments? Professor,
there's a question in the box, ma'am. It says, how can we incorporate HAIs and AMS surveillance? Is there any policy or guidelines for combined surveillance?
So who is taking that? I think, should it be Dr. Egwuenu or Professor Aboderin? Dr. Egwuenu, are you still on?
Yes, I am.
Abiodun, yeah. Maybe you should take that first. Yeah. Okay.
So yes, currently we have separate guidelines for policy and guidelines for HAIs and AMS surveillance. But the plan, I think, as Professor Aboderin said, is these two streams should closely work together and should be integrated. And there are some levels of care where by default they will be integrated. For example, we are plotting an antimicrobial stewardship program in secondary facilities. From our assessment, we found out that the same set of people that are in the AMS committee would actually be in the IPC committee. So there is no need having two different committees in this level of care. And then now talking about the primary level, because they are the same persons. What we need to do is for the committee to work, and then within this committee, there would now be teams that would look at IPC, hospital-acquired infection, antimicrobial stewardship, and diagnostic stewardship. So the way to go is actually integration. And this is one of the things we are looking at, and it will form the basis for our guidelines going forward, really integrating this aspect into one stream of work. Yes, so I do agree with the person that put down the comment, Dr. Rona.
Thank you. I can see two hands up. Chineye, and after Chineye, Dami Adeneye. Chineye, make it snappy.
All right, thank you so very much. Good to be here. Good to have the opening of the year with such excellent presentations and learnings. I want to thank all those who presented, and also thank the chairman for the presentation from the LUTH. I think I want to raise a little concern here. The penultimate presenter, the one before Choma, in one of the charts, showed us the increase in antibiotic use between up to about 2015 thereabout, an astronomical increase of about 63%. Now, I just want to ask, this piece of data that was displayed, I had a little issue with network about that time. Is it something that is in country, or is it something that is global? And if it is global or in country, does it have anything to do also with the astronomical growth in population? Is it a real increase, or is it something that is predicated on the population, or is it something predicated on an increased health-seeking behavior of the people, or is it something predicated on an abuse of antibiotics? Because to me, that's really astronomical. I think that's my question.
Thank you.
Then to Dr. Osuagwu, the presenter from LUTH. I must thank you very much for your presentation and all the sincerity and everything you displayed in the presentation and submission. But I have this little question or concern for you to help me out with. And that is in your use of alcohol-based hand rub and your consumption rate of the use. The consumption rate you told us has increased. Is it only in the pediatric ward that you were concerned about dealing with the outbreak, or is it generally in the hospital? If in the hospital, is it also among?
Thank you, Chineye. Let's take the last question so that they can take it together, because we're running out. I'm sorry, I'm cutting it. Dr.
Oh, no. Thank you very much.
Thank you. Dr. Adeni, can we have so that they can take it all together? You have the floor.
Thank you.
Dr. Adeni Dami.
Yes, I'm here. Can you hear me?
Yes.
Okay, thank you to all of us. I think that the question in the chat box.
You have to speak. You're a bit slow. I don't know. Just go on. Or you don't have any more questions?
Is it better? Can you hear me?
Go ahead.
Can you hear me? Okay, my question
I can hear you, though it's low.
Maybe you should move your equipment. Yeah, you may be too far from it.
No, I'm using earphones and I'm speaking into the mouthpiece.
Okay.
Can you all hear me? Okay, my question
is
it's
better now. It's better now. Go ahead.
My question is to Dr. Egwuenu. The report she showed us about the classification of the AWARE classification. I observed that for the last category, that's the one we're supposed to reserve antibiotics. We had a lot of 0% reported there. Now we know that we have fewer antibiotics.
Maybe you should type your question. Maybe you should type it because it's a bit faint. But meanwhile, let's have Professor Aboderin respond to Chineye's questions and concerns, and Dr. Oswald quickly. But meanwhile, Dami, can you type in the chat box and we'll read it out?
Thank you very much, and thank you for that observation. Yes, the volume of use of antimicrobials are increasing globally, just like Riley said. But you also know that the more any income a population or community, it's found out. In fact, much of that. Okay, to start, it's global. It's a global years of the volume of antimicrobial use that measured the increase between 2000 and 2015, and you have 65% increase. But it's also documented in that paper published in Lancet Infectious Diseases that much of that use is found in the low to middle income countries. So with more earning power, it's easier to access antimicrobials for different indications. So there's a lot of use for in those communities. South Africa, the BRICS countries, in fact, large number of the use is found in Brazil, China, India, and all that. Now we should remember couple years, of course, increased population would have, but whichever source, the more volume of use, the more pressure on bacteria, and the more the pressure to become resistant. So coming from increased access to agents added with increased population, so much antibiotics now pressing microorganisms to develop resistance and to become untreatable.
Thank you very much. I hope that takes care of that. Dami?
He's putting it in the box. And there is another question just before he's in the box. So 2 questions, one from Chukunonso and one from Dr. Adeni.
Can you just read it out, please?
Okay, the question from Chukunonso is, the antimicrobial stewardship guidelines are good, but not widely disseminated. Again, what's the plan to cascade and get a private hospital involved as well as monitored implementation? Then this question from Dr. Adeni is, I'm curious as to the reason for the 0% reported for the reserve antibiotics in your AWARE classification. Thank you. Over.
Okay. Dr. Oswag, there was a small concern from you from today. Then we'll have Professor Aboderin so that I can drink water.
Okay.
So, Chioma, quickly, can you just...
Okay, Chinenye, thank you for raising the concern. We did a hospital-wide training on standard precaution, of which hand hygiene is the most important aspect of standard precaution. And the uptake in the hand sanitizer is hospital-wide. Even admin people, everybody is looking for hand sanitizer. Maybe thanks to COVID and training. Thank you.
Thank you. So back to you, Professor Aboderin.
Yes. How about the private hospitals? Well, good enough. I think Dr. Egwuenu showed us a slide where it shows Nigerian National Action Plan. The lifespan of our action plan is this year. So Nigeria is considering a new action plan on antimicrobial resistance. I know that in 2017, when Nigeria started the national response, the plan then was, so let's get the government hospital public facilities, because the private hospital is another issue. But discussion has also been good, because we will not be able to totally have a address follow resistance when we do not bring everybody on board. And so definitely going forward, private hospital will be more engaged. At least in the new action plan, I think we would need to consider that in what we are doing. And she also talked about—
Yeah, go on, just random.
Yes, the AWARE classification. Why is it that there's 0% or so from the reserve class? Well, one thing we need to know that restricted number of agents in the reserve group, drugs like cholesterol, drugs like Abiodun Egwuenu, that I'm not sure Nigeria is import. Cholesterol, yes, we might, but it might even be difficult. A few times we had to use cholesterol in my facility, it had to be imported. So you get 2 doses now, you are waiting for another dose for it to be imported. So the drugs in reserve class are actually reserved in terms of even the availability in a country like Nigeria. So not to talk of cost, even when you eventually get them. Over. Thank you.
Thank you. I don't know if Dr. Abiodun Egwuenu wants to say a word or two. And before you take that, I want to say that I've heard so much about this, but there are so many patent medicine stores, because the community too, I think, need to be educated, because they go there and they just buy, they prescribe. What is government going to do about that? Thank you. Just a word to round up, and then we've had a long day.
Yes, thank you very much. Dr. Shivani. Yeah, so for the stewardship guidelines, as Prof said, we have a national action plan. The guidelines are not fully developed, but we are working very closely with the World Health Organization and other key stakeholders. Like for the antimicrobial stewardship pillar of the TWG, Professor Aboderin is actually leading for the country. So that coordination is from this angle and also with other key stakeholders. Now, talking about the 0% preserved antibiotics, this is what our data showed, that we didn't find any pharmacies with antibiotics. This might also mean that this might not be in stock usually because those drugs are quite expensive. So there might be more with distributors or wholesalers. When the hospital or the pharmacy needs them, they get them and then procure and sell. Most often might be directly to patients, but we do not have this data yet. But these are some of the things that we have taken into consideration and look at more in depth going forward. Regarding over-the-counter stores, yes, we need to educate the community, but we must also be aware that people do not have good access to healthcare. And that is a fact. There is the push and pull factors. So people are going there because they do not have access to healthcare. If someone has to go to the hospital, pay for consultation, pay for testing, pay for the pharmacy, for drugs, and add that to waiting time. The truth is, except you are highly motivated, and one of the motivating factors will be health insurance. If you know that the cost is so low compared to you going out there, then you have to look at the cost benefit. We still have that challenge in Nigeria. So we cannot say, oh, do away with over the medicine stores, because prescription only medicine, they are not supposed to sell antibiotics, yes, by law, but regulatory capacity is low. People will go there if they do not have any other way to access health. So we need to look at all these variables, and we are working with stakeholders to look at all this to actually respond, so that if people need antibiotics, they can get them. And if people that do not warrant antibiotics, they cannot access it easily.
Thank you all very much. And I'm sure the House, unfortunately, this discussion can go on for the next 1 hour, but we are short of time. Our time is actually up. I want to thank our presenters today. They've done so marvelously well. And the listeners, the stewards, because we are now all antimicrobial stewards. A lot is still going to go on behind the scene. We're still going to continue the discussions. I want to just thank everybody for making time out of no time. Where we normally have our session the last Thursday of every month. We wish to continue this year. We started very well, and I hope we'll continue on this tempo. Next month, we are hoping to do supplies in IPC. But we are talking, as part of the supplies is our antibiotics, but this is zeroing on antibiotics. So we're going to have Mrs. Omishori and her team tell us to make sure that our logistic management is well taken care of. We are thinking about very interesting topics. We hope we'll see you again next month. And I wish you all a very, very lovely afternoon. Thank you for your attention, but please give us your feedback so we can enrich our session and make it better. Thank you, and God bless.
Thank you very much. Bye.